So good morning. I'm very honored to welcome all of you to the first conference on climate change and health. Whether or not you're here in person or tuning in online, thank you for being with us here today. I'm Jill Baumgartner. I'm a professor in the School of Population and Global Health. I also direct the Center for Climate Change and Health here at McGill. Before we begin, I just want to take a moment to reflect on the land where we're gathered today. So what we now call Montreal has long been a site of meeting and exchange and stewardship among Indigenous peoples. And historically, this land, it lay near the boundary of the Haudenosaunee, so the Mohawk and other Iroquoian nations, to the south. And then the Anishinaabe lands to the north and the west. And the St. Lawrence seems to have been some kind of dividing line. And this area where Montreal now stands was at times shared, and it was also a place that seems to have been contested. So when Jacques Cartier first arrived in 1536, he came across Algonquin villages that were here in what is now Montreal and in Quebec City. And when Champlain came a few decades later, it had been replaced by Mohawk hunting grounds. This shift reflects a very long and complex history, often through colonial accounts, of the intermingling and trading and playing politics, the debates, conflict, but most importantly, the rights to these lands were never ceded or sold to the original peoples who inhabited them. And so today we acknowledge this place that has long been a site for meeting and exchange for Indigenous peoples, and we honor and respect them as the traditional stewards of the lands and the waters on which we're holding our conference today. And I think this recognition feels especially important as we face the accelerating climate disruption. We've all been experiencing record-breaking wildfires, heat waves that are inevitably going to happen this summer, and increasingly unstable weather patterns that threaten our health. They impact our livelihoods, and they also impact our ecosystems that we rely on. In the face of some of these new challenges, science is a really important piece of solving this. We need rigorous research to understand risks, to identify some of the most vulnerable populations, and to guide effective responses. But science isn't enough. And to meet this moment, we also need historical awareness, understand how some of the past injustices may have shaped the vulnerability that we see here in Montreal, but also globally. We need systems thinking to try to help us connect the dots across disciplines, across sectors, and across different scales and geographies. And we need humility, both in how we engage with each other, learn from different ways of knowing, and how we interact in the face of disagreement or uncertainty. And we're meeting this moment in a time of global uncertainty. Climate disasters are getting worse. We're still struggling with some of the health systems that are under strain. And in some places, including just across our southern border, science itself is even being attacked and dismantled in a way that I think wasn't really on people's playbook for 2025. But with every crisis comes an opportunity. And here at McGill and in Canada, we have the opportunity and really a responsibility to lead with evidence, with compassion, and with collaboration. And this conference is really designed to reflect that. So our theme, translating climate and health research into actionable solutions, asks questions like, how do we move from data to decisions? How do we move from analysis to impact? And how do we move from urgency to thinking about this in terms of equity? And you're going to hear from scientists and public health leaders from all across Canada who are going to speak about a wide range of issues. So from the health impacts of climate disasters to the tools and technologies that we use to respond. You're also going to hear later in the day from some of the local organizations here in Montreal who are giving us a sense of what grounded, inclusive, and community-driven leadership really looks like on this topic, what's happening right now here in Montreal. And I want to say this isn't a conference to just passively listen. We've got great science that I'm super excited about, but I want you all to use this space to connect and get to know each other and continue building this community that we started building in November with the launch of the Center for Climate Change and Health. This event has been about 9 months in the making. So before we begin, I just want to thank the planning team that made this event possible. All of the nice food and nice coffee that you enjoyed. This was thanks to folks here. And they also worked to find the support to make sure that this could be accessible to everyone with translation and both an online as well as in-person presence. And so with that, it's my pleasure to hand the mic over to the Dean of Faculty of Medicine and Health Sciences, Dean Leslie Fellows.
Thank you, Jill. It's my pleasure to welcome you today on behalf of McGill University and the Faculty of Medicine and Health Sciences. And to those of you from out of town, bienvenue à Montréal et bienvenue à McGill. I'm pleased to see such a diverse gathering of students, researchers, practitioners, community members. The concept for the conference sounds extremely pertinent in terms of bringing really different perspectives together and focusing on how to go from evidence to action. Special thank you to today's speakers who've joined us from across Canada and really bring a wide range of perspectives and expertise to the discussions. I don't think I really need to tell this audience, but the effects of climate change are increasingly visible globally and here in Quebec. And despite that visibility, in a way, the current moment seems to be obfuscating and kind of causing us to be distracted by matters that are perhaps less important. So it's great to have this conference to kind of refocus on what is truly a global and existential issue. It's affecting the air we breathe, the stability of our infrastructure, our economies, and our health. And we need to address the challenge with the same urgency and collaboration that we bring to any major public health challenge, and we've had recent experience doing that, and it's very possible for people to work together across the whole planet when they put their minds to it. Certainly at the Faculty of Medicine and Health Sciences, we see the current moment as a really critical inflection point. I think I would have been saying that anyway. Jill was alluding to the fact that at a moment when we really need to be working together, it seems that in many ways around the sort of scientific mission, we're under a lot of pressure that's pushing us apart. So I think it is time for us to act and to lead, and I hope that this event will be part of moving that forward. Climate action can absolutely improve population health. It could definitely reduce inequities and strengthen the systems that we rely on. And approaching problems through the lens of climate action, I think, is not only good for the climate, but good in many other ways. That's why at the faculty we've invested in efforts like the Center for Climate Change and Health, because we think that interdisciplinary community-connected research is important in general and specifically in this topic area. And McGill as a university has really been engaged with and seized by the crisis related to supporting sustainability for quite a while now and in a broad diversity of ways. And in some senses that breadth is kind of a double-edged sword. This is facing this very complex set of interlinked factors and crisis, and then how to really move into action. And I know the people here have thought about this, and I'm sure the day will be even more thought about that, and I encourage you to take the steps that make sense to be bold. McGill, I think, is particularly well suited as a institution to lead in this area. It has global connections, to say the least, but it's very anchored and rooted here in Quebec, and I think that combination makes for a strong way to move forward. We're able to convene internationally, and today's events demonstrate that, but also take local action. At the level of the faculty, of course, we're committed to training health professionals and researchers who are prepared for the climate challenges ahead and who are able to bring strong science to bear to guide the best possible response and to help shape how our systems respond to go beyond individual patients or even public health to the broader policy frameworks that we really need to make adjustments within. And this conference reflects that commitment. So you'll hear about the impacts of climate change, but also the innovations and the community responses and the policies that can shift the trajectory. I remain hopeful about the situation. I think we have no choice really but to do a good job of responding, and that the momentary distractions shouldn't take us off that task. I want to thank Jill, Amélie, Scott, Jura, Jonathan, and Eduardo, and the musical accompaniment, the organizing team for the hard work that they've done in bringing this event together, and I suspect that there's some hardworking graduate students in the background as well. There usually are, and making sure that it's open and accessible to all. I hope you'll ask hard questions, build connections. I really think that one of the I don't know if it's in the water, is it in the air? The ability to collaborate, to actually focus on problems and move forward rather than competing in unhelpful ways is one of the things that McGill does really well. So I hope that atmosphere permeates the conference and helps you to focus together not only on what's wrong but what's possible. I wish you an engaging and fruitful conference.
Okay, well, this is very exciting. Thank you so much, Dr. Fellows, for that, and also just for your general support. And Jill, for all of your hard work, and everyone that helped make this possible. The center has been a long time in the making, and we're all very excited that we're actually here together today. So with that, I'll introduce our first session speakers. So we have three speakers today that are going to be talking about various aspects of climate change and health. Our first speaker is Dr. Vincent Agyapong, who's a professor of psychiatry and global mental health and head of the Department of Psychiatry at Dalhousie University in Halifax. We also have Dr. Eric Lavigne, who's a research scientist at Health Canada, who's done a lot of very interesting work on various aspects of climate change and health. He gets a gold star today because he's actually in two panels, so you'll be hearing more from Eric in the next panel as well. And we also have Dr. Sarah Henderson on Zoom. She is Scientific Director of Environmental Health Services at BC CDC and the Scientific Director of the National Collaborating Center for Environmental Health. So Sarah and I are peers in terms of when we finished our PhD, but she's really one of my heroes in terms of turning research and environmental health evidence into action. She's a real inspiration. So before we get started, I'll just remind the speakers that you have a strict 20 minutes. Jill has given me very strict instructions that I'm to do a big dance if you go over 20 minutes. So please stick to 20 minutes. I will hold the card up to let you know. And because we can't see the screen if we're sitting here, we'll ask the speakers to just remain seated in the crowd, and then we'll come up for the panel discussion after. So with that, Vincent, I'll ask you to come up. Is the presentation ready to go? Okay.
Yeah, just click next. Is that the order?
Yeah.
That's it.
Thank you very much, Scott, and Julia, and all the organizers for inviting me to today's conference on climate change. Really excited. It's focused more on actionable solutions rather than talking about the doom and gloom only. In that respect, I would be not spending too much time on the disaster and the mental health effects, although those are important before we get to what I think is most important in terms of really the lessons that we've learned from the research and how we can be able to use that to support the population in times of crisis. So I don't have any particular conflict of interest. I, however, serve as a volunteer board chair for the Global Psychological eHealth Foundation that's been promoting digital solutions to addressing some of the psychological treatment gaps. In terms of learning objectives, be focusing mostly on three things. Just reviewing the literature related to mental health effects of disasters, particularly wildfires. And then I'll be focusing on Canadian studies and then getting into the most important part of the presentation, which I think is the impact of the Tech for Hope Digital mental health program on subscribers in Alberta and Nova Scotia during the 2023 wildfires. So by way of introduction, climate change has been referred to as the long-term shifts in temperature and weather patterns, and the WHO identifies climate change as a significant change with substantive threat to life, health, and well-being. It has been identified as a contributor to the increasing frequency of extreme weather events and natural disasters, including wildfires and floods. About 40% of Canadians would experience some form of a natural disaster in the course of their lifetime. It's believed that up to 54% of adults will report symptoms of depression which can last 10 years after the fact. And also about 1 in 3 individuals would experience some mental health symptoms after going through a natural disaster. By way of the general literature, there are several socio-demographic factors that have been associated with predicting those who are going to develop mental health problems in addition to pre-existing mental health conditions. And we also know that the most significant risk factor for mental health following any natural disaster is actually the disaster itself. There are so many other things. I mean, those who went through the 9/11, really because you were in the 9/11, incident, that's the most significant trauma. If you went through wildfires or flooding, that's the most significant trauma, and that's more predictive of whether you are going to experience anything. Children experience a range of mental health conditions: PTSD, anxiety, depression, stress, alcohol use disorder, and so on and so forth. So in terms of studies that we've done in Canada, during 2016, there was a big wildfire in Fort McMurray. I used to actually live in Fort McMurray at the time as a psychiatrist, having left Dublin. And I was part of those who were evacuated up north. So we decided to begin a study looking at mental health effects of those who experienced that. So we looked at 6 months after the wildfire. We looked at prevalence of anxiety, depression, and PTSD. So anxiety was about 20%, and there were various demographic and clinical factors that were predictive of those who were going to experience, anxiety symptoms. We also looked at likely major depressive disorder was about 15%, and again there were some factors that were predictive. The most significant factor that was protective against either anxiety, depression, or PTSD was found to be the support that people reported they received from friends, family, and members of the community. So if you look at this, for example, those who reported they received no support at all from family and friends were about 13 times more likely to present with symptoms of major depressive disorder. So this also PTSD prevalence was about 12.6%. We also looked at the quality of life during the 2023 wildfires in both Alberta and also in Nova Scotia during the more recent wildfires. And again, you could appreciate that those who lived in the wildfire impacted areas reported poorer quality of life compared to those who did not live in the area. 18 months, so the initial studies were 6 months, then 18 months after the wildfires, we actually saw the elevated prevalence of both anxiety, depression, and PTSD in Fort McMurray residents remain elevated, including in children. So this is actually a study that looked at the prevalence of these conditions in elementary and high school students and compared them with elementary and high school students in Red Deer, which is also in Alberta. And you could see that if you look at, all the various things that we looked at, they were markedly elevated compared to the same kind of cohort of students in red here. So again, 1 month, 18 months, we kind of looked at these parameters in primary care patients. Anxiety remained 18%, MDD, PTSD. And we also looked at school staff. So we looked at various, kind of cohorts of residents. School staff, anxiety, depression, PTSD was elevated. We followed up with a 5-year study to see if there was a reduction in these symptoms. So this actually in elementary and high school students, and there remain an elevation of both probable PTSD, probable depression and anxiety. And we also looked at cannabis abuse in these, and we identified that, kind of those who experience depressive symptoms, anxiety symptoms, were highly correlated with those who were likely to abuse cannabis, in addition to some other socio-demographic characteristics. We looked at resilience, and again, low resilience was very high in this population. And we also looked at predictors of likely MDD and PTSD, and also likely generalized anxiety disorder. In 2020, there was some flooding in Fort McMurray, and so we followed up with a 1-year study to look at really the various mental health impacts of this. We found prevalence of generalized anxiety disorder was very high, and similarly, MDD was very high in those who had been impacted. But the most important study of all of this in Fort McMurray, I think, is this study where we looked at cumulative trauma, because you can appreciate those who were there in 2020 might have gone through the wildfires of 2016. In addition, there was a pandemic of 2019. So if there are elevated levels of anxiety, depression, and PTSD, what's really accounting for that? Is it really the flooding, or is it the wildfire of 2016, or is it because of the pandemic? So what we found out was that for those who experienced the COVID pandemic, and either the flooding or the wildfires were 11 times more likely to present with generalized anxiety disorder compared to those who experienced only the pandemic. Everybody experienced the pandemic. There was no exception. But some didn't go through the flood and some didn't go through the wildfires. But if you compare that with those who went through both the COVID pandemic, flooding, and the wildfires, generalized anxiety disorder likely also increased by 18 times. So it means that really cumulative trauma really increases the levels of symptoms people experience. Like PTSD was 10% for those who had 2 traumas compared to 11% in those. Low resilience was 11 times, and then 12 times in those who experience all 3 traumatic events. So very quickly, I'm here to the most important that I think I'd like to focus a bit of time on this presentation. So during the 2023 wildfires, we looked at what we can be able to do to help, people who have been experiencing the wildfires and being evacuated and so on and so forth. During any time of disaster, it's always very difficult to mobilize enough human resources to support the population. I was there in Fort McMurray, and certainly, I was there in a camp with my patients, my children, my wife. I was focusing on my own basic needs, and really was in no position really to be able to be of help, to anyone. And there are so many, mental health clinicians who are in the same similar situation. So how do we mobilize resources, to be able to provide the care and support and psychological relief that people need? We successfully launched a program in 2019 during the pandemic that supported over 60,000 people in Alberta, and so we thought we probably can be able to do the same during the wildfires. So let's just listen to this short video, which is kind of gives us a summary of what the program is about.
Half of young adults will experience mental health challenges, which can affect thinking, feeling, and behaviour. Key stressors for mental disorders include societal influences, health problems, natural disasters, and personal circumstances. The treatment of mental ill health is frequently complex and costly, both for the patient and for health services. This can be due to the nature of the disorder and the high level of resources required. Mobile health technology offers a unique and innovative solution. Smartphone ownership is widespread. Text messaging is free for the receiver and requires little technical skill. Contemporary practice requires a robust empirical research base. This was rigorously undertaken for our supportive messaging programs. We used randomized, controlled studies and cross-sectional surveys to assess the efficacy of our supportive text messages. We conducted a randomized, controlled clinical trial in Dublin, Ireland. Participants with a diagnosis of major depressive disorder and alcohol use disorder were randomly selected to receive twice-daily supportive text messages for 3 months. The effect size for the intervention was large, with a statistically significant difference in the Beck's Depression Inventory Scale scores and a trend for a greater total number of days abstinent from alcohol in favour of the supportive text message group. A second randomised controlled clinical trial in Canada examined patients with major depressive disorder. They received twice-daily supportive text messages for 3 months. A statistically significant difference in key metrics was seen. Based on the encouraging results of these 2 trials, we developed the Text for Mood, Text for Support, Text for Hope, Text for PTSI, Text for Wellbeing, Text for Healthy Aging, More Good Days, and positive mental health programs, designed for broader populations who are struggling with mental health problems. Multiple language versions of some programs have also been developed. The Text for Mood and Text for Support program evaluations established that most participants felt the text messages made them more hopeful about managing issues in their lives, in charge of managing depression and anxiety, and allowed them to feel connected to a support system. Most felt Text for Mood and Text for Support improved their overall mental well-being. Participants in the Text for Hope evaluation self-reported significant improvements using the General Anxiety Disorder 7 scale, the Patient Health Questionnaire 9 scale, and Perceived Stress Scale 10. Participants were rated as having significantly lower risk of moderate to high stress, anxiety, depressive symptoms, suicidal thoughts, and disturbed sleep. Daily supportive text messages are a feasible and acceptable way of delivering psychological interventions to the public with mental health problems. Dr. Vincent Agyapong's Global Mental Health Research Group worked with partners to develop and evaluate this innovative tool to support people who have mental health problems. Resilience and hope present an opportunity to help close the psychological treatment gap for those awaiting treatment or as additional support.
Yeah, so we did launch the program in Alberta and Nova Scotia to support those who are being evacuated or impacted. And we followed up with a baseline survey, 6-month survey, 6-week survey, and 3 months surveys to see how people were doing. They received daily supported text messages for 6 months. So as you can see in the results there, in terms of change, in the main score from baseline to 6 weeks for subscribers, there was statistically significant reduction in the anxiety scores, the depression scores, the PTSD scores, and there was slight improvement in the resilience scores and also the well-being scores. We also tracked suicidal ideation using the NICE questionnaire on the PAQ 9 scale, and again there was a reduction in that. One could argue that people probably were just getting better by chance. So what we did was a naturalistic study where we took a 6-week period where we looked at those who had received intervention for 6 weeks, and we used their 6-week score to compare to the baseline score of new subscribers within the same 6-week period. So these were people who were in the same ecosystem. They were equally impacted by the wildfires. Everything else that was going on around them was the same. The only difference was that one group had received the intervention, the other group had not. And that's the results that you see there as well. which also highlights that there was significant reduction in all the pathological scales, and then the well-being and the resilience scales. There was significant positive improvements or positive effects for the intervention group. We also tracked the 3 months results, and again, we could see there was statistically significant reduction in the various parameters that were pathological, and an improvement in the resilience and the well-being. We looked at the prevalence of the various psychological conditions. So the sum of this is that we can certainly apply technology, to support people in times of natural disasters that are related to climate change. Text messages are geographic location independent, can be delivered to thousands of people simultaneously. They are not human resource intensive, they are cost effective, and they are evidence based. We've done multiple randomized controlled trials. So thank you very much.
Thank you so much, Dr. Agyapong. We'll save our questions till the end, as I said. So next we have Dr. Lavigne who'll come up and talk about his work on heat and health with some Montreal examples as well.
Right. Thank you so much for inviting me for this presentation today. I know I was supposed to give this talk earlier this month, and here we are now. So we all know that temperatures are increasing. There's a clear trend that temperatures across the globe are increasing. And this graph here shows some of the temperatures over time since about pre-industrial period. That we see a clear increase in global temperatures. 2024 saw an increase of 1.47 degrees Celsius greater than the pre-industrial area. So the idea is that we see temperatures increasing. Pretty much every last few years have been some of the warmest year on record. We see increases in extreme heat. We certainly know that heat waves are becoming longer, the duration are becoming greater, and we see heat waves occurring earlier in the season. And this is something that we see in pretty much every area across the world. So what is extreme heat? Well, of course, there are different definitions, and usually we use definitions that are based on thresholds. When temperatures get to a certain point, we define that there could be an extreme heat event going on, and if the temperatures are getting at this threshold for a certain number of days, then usually it's considered a heat wave. But the definition of a heat wave differs on whether we're located across the globe. The definition of a heat wave here in Montreal might be different than what we would see in Edmonton, for instance, because we don't see the same temperatures in those two cities in Canada. Extreme heat has been studied quite a lot, the impacts, the health impacts in epidemiological studies. Probably around the early 2000s, there's been a number of studies that have been conducted, especially following some of the major heat waves that occurred in Europe. Around 2003 in Paris and major other cities in Europe were hit badly by heat waves, and epidemiologists started looking at the extreme heat impacts on the healthcare systems and also on mortality events. And what we've seen over time is that there's a clear association between extreme heat and when temperatures are increasing with the number of people dying on a certain day, perhaps the day of the heat wave or the following days. And we also see increases in emergency department visits, hospitalizations, mainly for cardiorespiratory conditions, but there's quite a number of evidence looking at other health outcomes now, and we see that those other health outcomes are also associated with those extreme heat events. Those that are disproportionately impacted, for sure, there are populations that usually when there's a heat wave going on, public health officials will try to put major efforts so that those populations get the proper information regarding what to do during a heat wave. So this is a list of the usual populations that are considered at risk or more vulnerable. And we might not think about like the last one that's listed there, people living alone, but some studies have shown that actually this could be a risk factor for increased adverse health effects for people who live alone, especially people who are older. So the question is, how can we better adapt? And there are many adaptation strategies that have been put forward based on scientific evidence and based on also multidisciplinary research, not only coming from epidemiology, but also coming from the urban greening landscape background or people working in engineering. But how can we better adapt and find those vulnerability factors? It's still something that we're trying to work on. And and I know those maps here are small, and it's just to show you some of the research that we're currently doing on trying to identify vulnerability factors across small areas, because there's been a lot of studies out there that have looking at cities and comparing one city to another on whether this city has more green areas versus another city that might have less green areas. And nowadays we have very fine spatial resolution data where we are able to get information at the neighborhood level. And that's basically something that we want, because if we want to better adapt, better prepare for future heat events, we want to be able to identify those vulnerability factors. So here we have an example for Montreal. We're doing this similar type of approach for major cities across Canada. And this is the census metropolitan area of Montreal. And we mapped out basically different vulnerability factors across neighborhoods. And for this example here, we're using neighborhoods are defined as the first three digit of postal code. So it's called the forward sortation area. So it's a sort of a neighborhood level information, but we're going to try to go and have finer spatial resolution for each neighborhood. And we see here patterns where at the bottom we see maps of green space, and of course we have differences in green areas across Montreal based on different metrics that we're using. So in different metrics that we're using at the bottom, we're looking at tree canopies, so the amount of tree coverage in different areas. We're also looking at a metric called NDVI, which is a satellite-based measure. It captures sort of the level of green space using satellites. And when we do those types of studies, we usually look at associations using biostatistical approach. We look at the ambient temperature in a city, and we look at whether there's a number of people perhaps dying on that day when the temperature is increased. And this is an example of the type of approach that we used for Montreal, where we have sort of what we call a U-shaped relationship, where at both extremes we see increased risk of mortality. So on the vertical axis, you see the relative risk, and the horizontal bar shows the temperatures distribution across Montreal. So one line shows what we would see if we average the temperatures across the whole census metropolitan area. And what if we capture the temperatures at each neighborhood level and we get the number of mortality events for each neighborhood instead of aggregating the information at the city level? And we see that the curves or the lines are a little different in the sense that we are able to get better relative risk information when we get the information at the neighborhood level. So having more spatially refined information of ambient temperature and also the number of mortality events by neighborhood is usually something that gives us more precise results. And if we stratify our results by, let's say, social deprivation or material deprivation, which are socioeconomic indicators that we have using census data, and we have this information at the neighborhood levels, we are able to stratify. And what we see here is that areas that have low social or material deprivation have usually higher relative risks of mortality. And we see a similar pattern with green space, where NDVI, the satellite-based green space measure, areas that have low NDVI coverage usually have higher relative risk, and we have the same pattern for tree coverage. So areas in Montreal that have higher tree coverage usually have lower relative risks of mortality when there's extreme heat events going on. Now, the question that might come in mind is, well, this is great. We are able to see those patterns, but the predictors that we are investigating do not work independently. There's certainly some correlated issues going on here where we have areas that have more urban vegetation, more tree coverage, but there are also areas with higher socioeconomic status. And the opposite is true as well. So what we're trying to do right now is really trying to investigate the joint effects of those factors at each neighborhood level. And this is an example, again, using the CMA of Montreal, where we're calculating the relative risks, so the risk ratios across different neighborhoods. So the more red color, the higher the relative risks, and related to the extreme heat issues. And the opposite is true as well. And so in terms of adaptation scenarios, what we're trying to do is trying to figure out which factors are the most important ones that we want to emphasize, that we can actually say to public health officials and urban planners, let's work on those factors, because we know that those factors are important when there's an extreme heat event going on. And we found in some of the preliminary analysis that we did for Montreal specifically, we found that social deprivation and tree canopy coverage both are very important factors. So if we emphasize a lot on those two factors, we can actually decrease the impacts of extreme heat in those areas that have higher social deprivation and lower tree canopy coverage. So some of the next steps, it's really trying to put everything together, adding in perhaps some urban heat island effect. So there might be some neighborhoods that are more affected by urban heat island. And we know that comorbid conditions, people who have individual level health conditions, might actually be at risk. So there might be areas where we have people who have more chronic disease prevalence. And so perhaps we want to emphasize also on identifying those factors. One thing that the climate science is interested about when looking at the effect of extreme heat is what are the projected impacts? Because we want to know in the future, what is it going to look like in terms of the burden on likely the healthcare system? And so there are different scenarios of projection of temperatures that are being put forward by the climate science. These scenarios are called shared socioeconomic pathways. There are different scenarios that are out there. The scenarios are basically related to greenhouse gas emission trajectories in the future. In other words, if we end up increasing GHGs, we might likely end up in a situation where temperatures will increase drastically by the end of the current century. Or if we go towards a more sustainable pathway, will limit temperature increase. Now, reminding you that the Paris Agreement requested that temperatures would be limited to 1.5 degrees Celsius by the end of the current century. 2024, we had 1.47 degrees Celsius compared to the pre-industrial era. So these are the temperatures that are projected for Canada. And we see that the sustainable pathway projection is the one in red. So that's the temperatures that would be increasing across Canada by the end of the current century. So the temperatures would be increasing by about 0.5 degrees Celsius. And that's if we go towards a more sustainable pathway. If we go towards the SSP, that's the more pessimistic scenario, that would be a larger temperature increase. It would likely be around 6 degrees Celsius on average increase. So we did some studies and we projected the impacts in the future of the likely impacts of temperatures that are increasing and what would it look like on mortality events. And we see that if we end up in a more sustainable pathway, we still see an increase, and I'm not going to go through all those numbers here, but we see about a 5% increase in mortality events by the end of the century, even under a more sustainable pathway. Because temperatures would still be increasing, we would still likely see a number of extreme heat events increasing. But if we go towards a more pessimistic pathway, this would likely result in around 17% increase in heat-related mortality. And that's considering demographic changes, and that's considering that cold-related mortality would decrease. So in other words, the net impact would still likely be important. And perhaps some things that we're working on right now is trying to figure out the cost, the future costs of those projected health impacts based on those projections that we're doing. And what we see in those different graphs here that are quite small, it's that obviously the more pessimistic scenario is related to a more increased burden on the healthcare system in terms of direct costs of ED visits, hospitalization, but also in terms of mortality events, premature mortality occurring, and basically calculating this using statistical value of life. So this is a study that we did in Quebec, including the Montreal data. So to conclude, we know that there are vulnerability factors out there. We're trying to better understand those vulnerability factors in terms of better pinpointing at where we should put more emphasis in terms of actions. And we know that in Canada, for sure, we have an increase in temperature that are projected. It just depends on basically the scenarios that we're going to get into. And we know that adaptation is something that we put energy into, but mitigation in terms of actually reducing greenhouse gases, it's something that is certainly important. Thank you so much.
Thank you so much, Eric. So now we should have Dr. Sarah Henderson on Zoom.
Okay. Good morning, everybody, and thank you for inviting me to be here with you. I'm sorry that I couldn't be there in person. And if I go over 20 minutes, I'm super hopeful that Scott will come to the front of the room and dance for me. Actually, I might go over 20 minutes just to see that. So I want to talk very specifically about extreme heat and schizophrenia today. I know that we're focused on solutions as part of this conversation, and one of the ways that we can drill down into solutions is looking very carefully at the populations who are at risk. So before I get started, I am speaking to you today from the traditional, ancestral, and never ceded territory of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I live on the traditional and never ceded territory of the Stalo people and the traditional home of the Lacamal First Nation in what we now know by the very colonial name of Mission, British Columbia. My agency, the Provincial Health Services Authority, which is the mothership of the BC Centre for Disease Control, has been gifted 6 teachings in the Hul'qumi'num language from a Coast Salish elder. Number 2 of those teachings is Nutsamat. And what this means is we are all one. And it's a teaching that I love most among the 6 because I think it bears so much relevance to climate change, what we do to this planet, what we do to Mother Earth, we do to ourselves, and also establishes us as a collective. We are all one. And today I am presenting the work of many different people who are listed here on the side. My team at the BC CDC is in blue, and others who have participated are in black there. And I want to acknowledge that none of this work would have been possible without tremendous support from our colleagues at Health Canada. So the 2021 heat dome, I hope that most of you are aware of it. I don't want to spend too much time on it, but here's an image from June the 28th. And what you can see is that this thing is essentially parked over British Columbia. There's certainly impacts in Washington and Oregon is there, but this was a very much a BC event. And we experienced temperature anomalies that were, in some places almost 25 degrees over what we would expect at this time of year. And in many places, we measured temperatures that were fully 5 degrees hotter than had ever been measured before in those regions. It's hard to explain to anybody who was not present for this event how hot it was. And what we observed was that there was a significant impact on mortality, as is often the case with this type of extreme event. So what we have on the bottom here is the number of daily deaths, and what we have on the top is the population-weighted temperature experienced across the province. On the hottest day, on a population-weighted basis, you can see it's almost up to 40 degrees. And green lines indicate that that number of deaths is statistically normal based on the past 10 years of data. Orange lines indicate that that number of deaths is rare, and then red lines indicate, we're something statistically different from what we would expect. And we use this concept of excess mortality, or the difference between what was expected and what was observed, to talk about the overall impacts of the event. And so when we add up the excess mortality across these 8 days that were most impacted, that adds up to about 740 excess deaths. And then if you followed this event closely in the news, you know that 619 deaths were directly attributable to the heat by the BC Coroner Service. Now, where those deaths happened matters. On the left-hand side here, we show the excess mortality by age, and you can see that for all ages over 50, there was about a doubling in mortality. We do not see such a large impact in people under 50. In absolute numbers, the deaths were greatest in those under 85, but we have to remember that that is true on any given day. Then when we look at where people died, we see small increases in acute care, small increases in residential care, and very large increases in deaths in the community. And this is a hallmark of extreme heat events. And it happens because of a phenomenon called indoor overheating. People do not die for the most part because it's too hot outside. They die because it is too hot inside. So these data show temperatures in 3 locations. The black line is Abbotsford International Airport. The blue line is a home in Abbotsford with central air conditioning. And the red line is a home in Abbotsford without air conditioning. And what you can see is that this home with air conditioning maintains a safe, steady temperature throughout the entire event, whereas this home without air conditioning follows the trend of the outdoor temperatures. We see these day over day increases, but there's two really important differences between the indoor and outdoor temperatures here. The first one is that the peak indoor temperature happens 3 to 4 hours after the peak outdoor temperature. This is going to be about 6 p.m. This is right after the summer solstice. This is 9 or 10 p.m., so right when people are thinking about going to bed. And then the other key difference is that when the outdoor temperatures come down overnight, they're still very high. These are tropical nights by the climate definition, but they're safe temperatures from a human health perspective. The indoor temperatures only drop a couple of degrees, and then they go up again, and then they go up again. So we have this home in what we call the danger zone. It's over 31°C for 4 solid days throughout this period. So we have done a number of studies on this event, and I'm not going to get into the methodological details here because I don't have time. But our first study was a case-only design, meaning that we compared people who died during the heat dome with people who died at the same time of year during previous years when there was no extreme heat event. So we're comparing deaths to deaths, and that's why we call it a case-only design. And the primary finding from this first study that we did was that schizophrenia was the primary risk factor for mortality when we use this design. We see a very large increase in risk associated with schizophrenia, and then we see smaller increases in risk associated with the types of conditions that are kind of more conventionally mentioned when we're talking about extreme heat. Chronic kidney disease, ischemic stroke, Parkinsonism, ischemic heart disease. And those are the types of things you normally hear about. And so why schizophrenia? Why is there so much risk associated with this group? And what we found is this was true among the heat-related deaths. It was true among the non-heat-related deaths. Like, we just saw this overall increase associated with this condition. And the thing is that this is an incredibly complex condition. So first, people with schizophrenia often display something called anosognosia, meaning they have very poor insight into their own health status. Second, there are physiological impacts of schizophrenia that I'm going to talk a little bit more about that other people may not have. Third, it's often associated with significant social isolation, socioeconomic deprivation. There's behaviors that come along with schizophrenia that other people may not have. There's multiple comorbidities that we often see with schizophrenia, especially substance use disorder and diabetes. And then there's medications that people take that put them at risk because they affect thermoregulation. So there's just a lot of stuff happening with this condition. Now, these are data from a very small study. We've got about 6 people with schizophrenia. I think there's 7 without schizophrenia, and they are not medicated. So any differences between the group are not due to medications that they're on. And this is part of a much larger review that Natalie Kirby is doing at University of Ottawa. But what I want you to note here is the resting heart rate for people with schizophrenia versus people without schizophrenia when they're at rest. So without schizophrenia, we exercise, have a rest, heart rate drops significantly. Exercise, heart rate drops significantly. In people with schizophrenia, you don't see that pattern. Heart rate stays very high despite a significant period of rest here, goes up again and stays very high again. So this indication that the cardiovascular function of people with schizophrenia might be somewhat different from those without. Our next study was a case control design, meaning that we compared people who died during the heat dome with similar people who survived. And we really focused here on chronic conditions and social vulnerability. And when we say social vulnerability, the key indicator that we're looking for is called Plan C. And this means that someone receives their medications in British Columbia under the Pharmacare Plan C, which is automatic enrollment for anybody who is on financial assistance in the province. So we see it as an indicator of living in poverty or living in near poverty. And when we look at the effects of all of these same chronic conditions, and we have Plan C, we can see first that Plan C has a bigger effect than any chronic condition in here. So an indicator that poverty was an important risk factor. And then we see that schizophrenia was the next most important risk factor. And this is not yet published, but we are working on it. And I want to say that it comes out of a conversation that I had with Scott's class last year when I was in Montreal and had the opportunity to give a guest lecture where I was talking about some of the methodological considerations in the case-only design and the case-control design. And one of the students said in the class, well, why don't you take a difference in difference approach? And I thought to myself, why don't we do that? So what we have here, again, I'm not going into the details, but statistically speaking, we have the risk when there is no extreme heat event present, and the risk in red when there is an extreme heat event present. And then we can look at how the risk differs, again, across these conditions that we're interested in. So when there is no extreme heat event present, here's the risk associated with poverty. It's always high. People who live in poverty are more likely to die than people who do not. But when the EHE is present, we see this big difference. However, when we look at substance use disorder, antibiotics, I don't want to talk about that too much right now, heart failure, chronic obstructive pulmonary disease, we don't see the same degree of separation between risk in the EHE or extreme heat event versus non-extreme heat event conditions. And then when we get down here to schizophrenia, we see this huge separation between them. Indeed, there's low risk under normal conditions and very high risk under extreme heat conditions. The forest study, we did a population-based case control among people with schizophrenia. So we compared the people with schizophrenia who died during the heat dome, and there were about 140 of them, with people with schizophrenia who did not die. And there's about 50,000 of those controls in this group. And once again, we are looking at risk factors in this group. So the primary risk factor of concern for us was antipsychotic medications. We're also looking at Plan C. We're looking at sex, and then sort of these indicators of disease severity that we can pull from the administrative data. So the number of ED visits an individual had had, the time since they entered the schizophrenia registry, the number of inpatient visits that they had for schizophrenia, and the number of outpatient visits that they had. And what we see is there's not actually too much risk associated with these things down here. ED visits, there is some risk. Being male, there is some risk. But the biggest risk factors are having been dispensed an antipsychotic medication in the 30 days before the heat dome, and once again, being on income assistance. And then when we break this down to look more specifically at the types of antipsychotics and the use patterns, we see that there is variability. So the biggest risk was among those who were on combination therapy, meaning that they were using 2 or more antipsychotics or an antipsychotic with lithium. Whereas monotherapy, there's still increased risk, but the risk difference in risk between the two groups is quite large. There was not a significant risk associated with injectables. That's a long acting antipsychotic. And then we see the different individual antipsychotics, and we know that there's varying risk depending on the anticholinergic properties of the medication. So among those we considered, haloperidol and clozapine, both very powerful anticholinergics, we see the highest risk among those two medications. And then the last study I want to talk about is a very deep dive into 20 different patients. And we're looking at 10 people who died with schizophrenia in the community of heat-related causes during the heat dome, and 10 matched controls who did not die, and looking at their patterns of healthcare usage over time. Here on the left-hand side, we have outcomes that are kind of all outcomes, and on the right-hand side, we have outcomes that are more related to psychiatric outcomes. So we've got all medications dispensed, antipsychotics dispensed, all outpatient physician visits, psychiatric visits, all arrivals to hospital by ambulance, and those for psychiatric conditions. And a couple of things I want to point out here. Very large difference in antipsychotic dispensations over time. In general, there is higher outpatient physician usage among the controls than among the cases. This was not true for antipsychotic outpatient services until the pandemic, where we see a switch between the controls and the cases, and we start seeing higher healthcare usage among controls and lower healthcare usage among cases. And then one of the things we really noted is that there's these very stochastic increases among cases for emergency type events, not necessarily specifically psychiatric emergency events, but we see that things kind of go off the rails for cases far more often than they do for controls. And then when we look at the patterns of medication dispensations between the two groups, what we see is a lot more antipsychotic dispensations for cases than controls. And then probably the most important finding from this study is we actually had 4 cases that were receiving their antipsychotic medications daily. You can only see that for 3 lines here, but there's 2 people who were receiving risperidone daily. That means they are having daily contact with a community pharmacist. And there's lots of different reasons why somebody might be dispensed their antipsychotics daily. We can get into that during the question period if you're interested, but it obviously presents a really clear opportunity to intervene with this highly susceptible population. And the final thing I want to say is that when we do deep dives like this into populations at risk, we can identify ways to protect people. And when we're talking about schizophrenia and the risk of schizophrenia, the thing I most often hear is, well, it's the drugs. Well, it's the antipsychotic medications. And there's this real dismissal of all of the other complex factors that come into play for this population. And these are some data that we prepared for that review being done by Natalie Kirby. And what I want to show you is this is the risk of schizophrenia, mortality among people with schizophrenia during the heat dome when not adjusted for anything else. So very high. And then we adjust it for the other chronic conditions that people had, and still very high. And then we adjust it for the chronic conditions and the medications they were taking, still very high. And then we adjust it for the chronic conditions, medications, and indicator of poverty. And there is still risk for this population. It's a very multifaceted type of risk. On the other hand, when we look at just antipsychotics, and we adjust antipsychotics for the chronic conditions and we adjust them for the pharmacare plan, what we're seeing is that this risk is now starting to cross the null line. So boiling it down to just antipsychotic medications for people among schizophrenia is really not telling the whole story, and it's dismissing risk among a highly susceptible population. We need to do better. Thank you. I don't know if Scott's dancing or not, but I hope that was pretty much on time.
Thank you, Sarah. I liked you before your talk, but I like you even more now because I didn't have to dance, so that was good. Before we have the panel discussion, I'm going to talk a little bit about some of the work we've been doing in the center on wildfires and cancer, and then we'll invite the speakers to come up. Good. Okay, so one of the things that my group at McGill has been doing, we've been moving a lot into climate change issues around heat and air allergens, but wildfires and cancer is one that we've been interested in for a few years. So it used to be that wildfires were things that would happen, there would be a sort of couple days of elevated smoke, and then they would go away and everyone would move on with their lives. And mostly we were talking about forests that were burning. But now that really isn't the case, right? So when we talk about wildfires now, it's often cities, it's neighborhoods, it's homes. Think about all the things that are in your house, right? Your clothing, your appliances, your electronics. Those things are being destroyed. So this is a picture from Los Angeles. And they're being released into the environment, right? So that's different than a forest burning. When a forest burns, a lot of horrible things are released, there's no doubt about it. But when cities burn, it's amplified, right? So there's a bunch of other things that are released into the environment that can harm our health. So this is a picture from Hawaii a couple of years ago, right? So vehicles being incinerated, all of those metals being released into the environment. This is from Jasper, again, homes, neighborhoods being destroyed. And so if you watch the news, the main pollutant that you hear about when it comes to wildfires is PM 2.5, right? These small combustion particles. This is a picture of New York City from 2023, from a Quebec wildfire that impacted Montreal, but really landed on top of New York City and turned the sky orange. The sky turns orange because these little particles filter out the blue light. There's so many particles in the air that they're filtering out the blue light, and the sky turns orange. So, but when it comes to thinking about wildfires and cancer, we need to think about more than just PM 2.5. Right? So there's a lot of things that are released by wildfires that is not captured by just saying what's the mass of a certain kind of particle in the air, right? So, and many of these things are known human carcinogens. We don't need research to tell us that. We know that these things cause cancer, right? So these are things like polycyclic aromatic hydrocarbons, the same things that are in cigarette smoke that contribute to cancer, dioxins, transition metals, things like nickel and arsenic, so all of the metals in your appliances and vehicles, electronics, when those things burn, they're released into the environment. VOCs, like benzene, causes leukemia, right? So there's a whole mix of harmful things that are released into the environment from wildfires that don't get talked about as much as things like simple PM 2.5 measures. And so interestingly, recently IARC classified the occupation as a firefighter as a group 1 carcinogen, right? So having a job as a fireman or a firewoman is known to cause cancer, right? So that says something about what these people are exposed to in their work. I can't think of another occupation that is a known cause of cancer, right? And so how do we get exposed to these things? So the obvious ones are obviously through indoor and outdoor air, right? So we talk about outdoor air quality, but the importance of indoor environments, like Sarah was talking about indoor heat, indoor air is very important when it comes to our exposures to carcinogens. So wildfires release these carcinogens into the environment, but of course they move inside of our home. We spend about 90% of our time in our homes. So these harmful components of air pollution, like PAHs, they infiltrate indoors. They can deposit on indoor surfaces, which means we can touch them, right? We can ingest them. If you have little kids at home, you know how disgusting they are. They touch everything, right? They put their hands in their mouths, right? So this is a source of exposure for young people, and it's a source of dermal exposure. And because cancer is really a chronic exposure, right? You need to be exposed over a certain period of time. these chemicals, they can remain indoors for extended periods of time because they're protected from weather and sunlight and things that would cause them to break down. Not only that, when it comes to PM 2.5, which is really just a mixture of stuff of a certain size, wildfires actually change the chemical composition, right? So the PM that's produced from a wildfire is not the same as the PM that's coming out of Fairmont Bagel, right? Especially if it's a city that's burning, right? So we see that there's elevated content of certain transition metals, some of which are important for cancer, but also contribute to things like oxidative stress and inflammation, which again are causes of the sort of mechanism that can lead to cancer. So it's changing what's actually in those particles we're breathing in. It's not just increasing the number of them that are present. Now, you might not think about this, but wildfires can also increase the carcinogens that are in the soil, right? So there's a certain amount of chromium that can be present in soil, just as a naturally occurring element. But the extreme heat of wildfires can actually convert that chromium into its carcinogenic form, hexavalent chromium. And more intense fires lead to more contamination deeper in the soil layer, right? So if you have a wildfire that converts this chromium into its carcinogenic form, then it's present in the soil. That soil can be tracked inside your house, where again, it can contribute to exposure. And as you see on the figure on the right, again, importantly, is that this contamination can last nearly a year after the fire, right? So we're thinking again about cancer because it's a chronic exposure. This sort of long-term presence of things in the air and soil are important because it extends the opportunity for people to be exposed to carcinogens from fires. And the third one is one that I hadn't thought about as much about, but water. So you might not know, but wildfires can damage the public drinking water infrastructure, some of which is made up of plastics. When those plastics get heated up, they release chemicals like benzene. And that benzene can then remain in the water for extended periods of time, contributing to cancer risk in exposed populations. And this can't be filtered out, right? So there's a pyrolysis of the plastic that happens, those VOCs leach into the water, and now we have carcinogens in the water supply. So wildfires contaminate our air, our soil, our water, our indoor air. So what can we learn about this in terms of population health effects? So one of the studies that we did as part of the center that was led by my PhD student Jill Korsiak is that we leveraged some very unique Canadian data that was available. So Natural Resources Canada actually has data on the location and size of fires across Canada going back to the 1980s. And we linked that information to 2 million people from the national census cohort. And we followed people over time. So we can update people as they move throughout their lives, and we can assign them exposures to wildfires. And the way we did this is we essentially assigned people a metric of the size and area burned basically around where you live. And we did this because we wanted to capture not just the air pollution from a fire, but all those other sources I just mentioned, right? So if we just focused on PM 2.5, we're not really capturing all those other sources of pollutants that could be present from the fire. And so we're using this as a surrogate measure of sort of all the horrible stuff that comes off a fire, the way you would look at, say, residential proximity to a busy roadway, for example. And when we do this, we looked at various different radiuses of where the fire happened, but the two main takeaways were pretty consistent signals of increases in brain tumors and increases in lung cancer. And this was independent of traditional PM 2.5 measures. And we saw this for different moving averages, whether we looked at, say, 3 years or 5 years or 10 years exposure. And for brain cancer in particular, this is interesting because we don't know a lot about what causes brain tumors, right? So there's probably some environmental factor that contributes, but we don't know a lot of the environmental factors. So this was an interesting finding for us. Now, surprisingly, not many studies have looked at the long-term health risks of wildfires, particularly cancer. The ones that do exist tend to focus on what they call wildfire-related PM 2.5. So this is PM 2.5 that comes from fires. And these studies tend to see some elevated risk. So here there's a study that was done in Britain that saw an increase in total cancers and also lung cancer. But these sorts of exposure measures focusing on wildfire PM are really underestimating the total impact of fires on cancer because they're focusing only on this one source of the exposure. So what can we do about this? So we certainly need more research on understanding population exposures to wildfires and carcinogens, but it's important to recognize that we know these things are bad for us, and there are things we can do to reduce exposure. So one of the very sort of inexpensive things you can do is the same thing we did for COVID, right? So there are sort of do-it-yourself plans you can get. You can go to the hardware store and buy the materials to make these indoor air filtration systems with duct tape and a box fan, and they're highly, highly effective at removing these airborne carcinogens from the air. It's the kind of thing that, had we done earlier in COVID, probably would have saved a lot of lives because of the airborne transmission. Now, I do want to point out that Jill is organizing a workshop at NDG to actually build these with the community. So if you live in NDG, please go out and participate. This is the kind of thing I think we're pretty excited about with the center, is sort of getting involved with the community. Other things that I think we need to think about in terms of exposure reduction, if you think about people who work outdoors, right? So if you're working in an area that has been impacted severely by a fire, it's a very good idea to be wearing masks to filter out not only particles, but masks that will also filter out gases and vapors. Particularly if you're in an area that was heavily impacted and you're returning back to your home, right? You want to make sure that you're not exposing yourself to these harmful materials. You want to avoid tracking that soot and ash that could be contaminated into your home, right? You want to clean the indoor surfaces to try and minimize people's dermal and ingestion exposures. And also ask about the water quality, right? So I think this is one that people don't necessarily think about, but it's one that has been documented in a number of locations. And I think people don't necessarily think about that when they're thinking about fires. Now, I do want to just briefly highlight some of the work we have ongoing in the center, where we're trying to really understand patterns of mixtures of harmful components and how they vary throughout the wildfire season. So I'm working with Dr. Eric Coker at the BC CDC and Dr. Crystal Pollitt at Yale. Crystal's developed this really nice passive sampler, which is shown on the right there. So it's just this little clip that has a magnet coated with a solution that can passively absorb a range of chemicals. And so we can look at temporal patterns in literally hundreds of chemicals and how they vary with wildfires. And we're trying to get a sense of how carcinogens vary throughout the wildfire season, so we have a better sense of what people are exposed to and how that might ultimately contribute to cancer risk. So with that, I just want to thank you, and I will invite the speakers to come up. Can we get Sarah back up on Zoom? So I guess if people in the audience have a question, they can go to the microphone. Is that correct? Okay. Okay, so are there any questions in the audience before we get started? Okay, I'll start. I have a question for Vincent about the logistics of using text messaging. So, I mean, how do you collect that information in a community prior to fires, or how do you collect the information you need to send out those sort of alerts to people?
Yeah, so I mean, this is actually an automated program that's online program, and usually people self-subscribe by seeing an advert, hearing about it on radio, and it's very simple by just texting a keyword to a short code number. And in terms of how we gather the data, usually the first text message that people receive when they subscribe contains a link to the baseline survey, and then there's a link also at 6 weeks, at 3 months, and then at 6 months that come to you. So the logistics are very simple. There's no need to kind of log in, create a password, provide any identifiable information. It's just as simple as texting. For example, you can try now if you want by texting just Hope AB to a phone number 393939, and immediately you'll be subscribed to the program. And that's about all the effort that's required from anybody that's seeking help and support.
Excellent. I was trying to do it while you were talking, but I didn't have time. First question in the audience, yeah.
My name is Lisa Bornstein, and I'm also a member of DEEP and a faculty member in the School of Urban Planning. I have first just a quick question for Eric about, maybe I just missed it, your definition of social deprivation and how robust do you think that is, or what limitations, whether it's just census data at a particular moment, whether there's some sort of longitudinal component to it. So that was one thing. And then Sarah, just fascinating, wouldn't have thought that schizophrenia would have all of these risk factors. And I just wondered whether some of the attributes of schizophrenia, whether it's delusional or, that whole question of self-care and self-awareness, how much that might be a compounding factor. Thank you.
Thank you for the question. So regarding the social deprivation, it's based off census data, and it's usually based, so the data that we used was, we assigned the nearest census, so 2021 or 2016 and so on. And it's usually, the index is usually based on a number of other factors that are found at the dissemination area. So dissemination area is usually a small neighborhood area where we have about 400, maybe to up to 700 people living. And it's an index created off whether there's a number of people that have poor housing conditions, that have low-income quintile. So there's a number of factors that are being put in this index that are derived into creating this deprivation, social deprivation index. And then we create sort of a quintile variable for this index.
Sarah, you can.
Yeah, but first of all, I can see myself in the room, and I am gigantic, so it's a little awkward. So in terms of, so again, I'll come back to this question of anosognosia, which is essentially lack of insight into your own health status. And it's said that up to 90% of people with schizophrenia demonstrate anosognosia, and essentially the more severe the schizophrenia is, the more severe the anosognosia is. So I think it's a really big part of this complex question. And when we engage clinicians, and I have to say, I am not a clinician, I am not a psychiatrist. This is new work for me, and I'm learning a lot about schizophrenia as I go. But when we engage them on the question of the kind of daily dispensations, the times when these are indicated are for those patients who have very low insight into their own health status and really do need the daily dispensation to ensure adherence to their medications. Those who are taking the quite potent medications that for which there could be risk if they skipped one or more days of the medication. And then finally, those who are on kind of community monitoring, which allows a daily touch point with the medical care system. And then that touch point is tracked so that folks know that that patient is on track and doing okay. So it is a pretty severe kind of group of cases that would be receiving these medications on a daily basis. But what I learned is that it's not because they're, at risk of overdose or anything like that. It really is the patients who need that kind of daily structure.
Thank you, Sarah.
Hi, I'm Anna Diacono from the Geography Department. And I have questions both for Sarah and for yourself, the moderator. I didn't quite catch your name. But I'm wondering if either of you can speak to any comparisons with research from the Global South. Sarah, what came to mind during your presentation are locations that often have extreme heat and also do not have air conditioning, for example, and I wonder if, you've engaged with any literature, if there is any literature that's similar to yours from the Global South. And then for the moderator, Scott, thank you. What came to mind were all of the places where burning trash is commonplace, and I wonder if, you can speak to that at all in context of what you spoke about earlier with when cities burn, of how that's different than when forests burn. Thank you.
Thank you. Sarah, you can go ahead.
Okay, first I'll preface this by saying I am the scientific director of environmental health at the BC Centre for Disease Control. My research focus is very much on the population of British Columbia, so I don't engage too much in kind of international research and global research. I'm not familiar with risk among people with schizophrenia in the Global South. I am familiar with the fact that there is a huge lack of extreme heat research in the Global South, and I would imagine that this population is even more marginalized in those types of locations than they are in high-income countries like Canada. So I don't know what's out there, but I'm guessing it's not very much.
Thank you, Sarah. So your question about trash burning is a good one. So I've only been involved in one study that looked at that, and it was actually in response to an emergency in Iqaluit, where it wasn't being burnt intentionally, but the landfill caught on fire. And we did all kinds of monitoring around that, and a lot of very harmful compounds are released. The one compound that we measured in much higher levels than would normally be seen were dioxins, which are formed when you burn plastics. And so in places where trash burning is just the standard of waste disposal, for sure within some radius around that activity, there are going to be elevated concentrations of carcinogens. The population health impact will really just depend on the prevalence of the exposure, but it's for sure a source of those same kinds of compounds.
Hi, Steve Martin, in the Occupational Health Program of VBOH, and my question's for Scott. These wildfires are a relatively recent phenomenon, probably not many, more than 10 years ago. Are you going to be careful to allow for the latency period in your studies of the effects in occupational cohorts? For example, lung cancer would appear in most studies to take at least 10 years to develop after last exposure, and in the case of aniline dyes, it's even 30 years or more. So are you taking that into consideration?
So if you look at the Lancet paper that I was talking about, we had a number of different lag periods that we looked at. And I mean, I think the wildfire issue has been in the media for 10 years, but they've been happening for a long time, right? I mean, the data goes back to the 1980s. The one thing that was funny in 2023 is that because Toronto had smoke, the Globe and Mail was really, really worried about wildfire smoke all of a sudden. But I had to remind them that BC has been dealing with it for 15 years every single year. And so the idea that it's new, something happened psychologically in 2023 that people just were like, oh man, this is like a thing. But the reality is that many communities have been dealing with this for a long, long time. It just wasn't on Bay Street's list of things to worry about. But the issue of latency is well known in environmental epidemiology. Sometimes we're limited by the data we have, but in terms of wildfires, it's actually quite good because we can go back so far. And the lung cancer and brain cancer signal was there even when we built in those lag periods, so it's still. Marianne?
Yeah, thank you. Marianne Hetzapru, Civil Engineering, University of Toronto. I have a question, it's probably for all the speakers. I'm going to start, Eric, I really like the scenario analysis that you did at the end, looking at these IPCC scenarios and translating that to what does this mean for Montreal, and what does this mean from an EPI population point of view? And we understand there's a lot of uncertainty, right? IPCC scenarios are uncertain on in their own right, and downscaling is uncertain, but it's very powerful for policy to kind of understand what is the cost of doing nothing, right? But also moving on to, the other speakers, and I know Sarah and Scott, you both talked about, the quality of indoor environments, indoor temperature, indoor air quality. Jill, you're doing stuff at a community level, which is very important, but policy is also very important. I'm wondering, the question is, and it's more like a research question, how feasible is it, and maybe, starting with Scott and Sarah's perspective of, from an EPI point of view, to quantifying the benefits of these solutions, right? Like if everybody had that kind of filter, or Sarah, if everybody had, a better quality housing, what does that actually mean for population health at a Canadian context? Because I think this would have massive impacts for policy. I don't know if the research is there, and if it's not there, what are burning research questions?
This is a great question, Marianne. Sarah, maybe you can start, and maybe also talk about the ASHRAE regulations you were involved in as well.
Sure. Regulation's a strong word. It's a guideline. So where to start? Let's start with the idea that if everybody in BC had access to a thermally safe environment during the heat dome, we would have had no heat-related deaths, or very few heat-related deaths. And I believe that to be true. So how do we walk backwards into the policy that allows us to ensure that everybody has a thermally safe environment? And then how do we prove that that policy is working? In terms of how we walk backwards, we start changing the building code, and we will see this evidence reflected in the 2025 building code when it comes out. I believe, as things stand, all new builds will be required to be able to maintain at least one indoor space at 26 degrees C, regardless of what's happening outside. That's already been implemented as bylaw in Vancouver. Then there's work to do for retrofit, obviously, for the existing building stock. But I think we slowly build towards a place where people do have thermally safe environments. How do we know if that is working? Well, we track what happens during extreme heat events. And I will say we very carefully track what's happened after extreme heat in BC since the heat dome. We haven't had another heat dome, obviously, but we have had very hot summers since then, like significantly hotter than we were having pre-heat dome. And we're actually in a place in the province right now where we have deficit mortality on days when we have a heat warning in place. So the structures that we've built up to respond to extreme heat, and that experience of the 2021 heat dome was really a wake-up call for the population. We now see that there's a different impact of extreme heat than there was previously. And I have to track that and report on that provincially. And then looking at the ASHRAE work, so, finally, we now have some guidance around how to keep smoke out of buildings from the premier agency that provides this type of guidance, which is ASHRAE. Other people have done similar types of work, but the engineers have come in and said, this is how to do it. So we have a template for retrofit. We have a template for new build. What we do not have is an indoor PM 2.5 standard. And I think that is the missing piece in Canada right now and lots of other places, because it's very hard to tell people you should be aiming for this value when there is no value to aim for. So much like we're kind of moving towards 26 degrees C as the standard for the upper level of how hot it can be indoors, we need something similar for how much PM 2.5 there can be indoors.
Yeah, I think I agree with all of that. In theory, we don't really have an outdoor standard either. It's really just a guideline too, right? It's not it's not like the US where it's actually enforceable. I think if we learned one thing during the pandemic, it was that there's a lot of hesitancy to regulate indoor environments because of how expensive it is. My thoughts around sort of research, we just talk about indoor air filtration. We already know that works. Like, I mean, Jill and I have talked about this. There is a benefit to showing people that it works in their community, in their schools, in their homes, but I don't think you need to do that in every home and every school, right? I mean, I think there's enough evidence out there showing that it works. Getting people to adopt it it will save lives. Not just from air pollution, but viruses. Imagine if daycares had these things, how many fewer sick days there would be for the parents and the kids and the daycare workers, right? So I think there's a lot of population health benefits to doing this. My own kind of thought is that we should just do it. Not everyone would agree with that, but I feel like we know that it works, so it should be implemented as much as it can be. Yeah. Yes.
Hi, I'm Thierry Oliman. I'm a research coordinator at the University of Montreal School of Public Health. Sorry, my English is a little bit rusty, so I'm going to do my best. I was wondering, in the studies you presented, maybe especially our two first speakers, but it's working for you both too, Sarah and Scott, that's it. I was wondering whether disability was considered as a risk factor, because we heard about young children, old people, and so on, comorbidities, but disability itself was not explicitly mentioned in these studies as a risk factor, but also when we're developing tools or like Text for Hope. I know that there is a wide range of disabilities, so this is in itself a challenge. But yeah, whether this factor was considered in the design also for the strategies or prevention recommendation that can be made, like reducing exposure or something like that.
That's an excellent question. Vincent, do you want to go first?
Yeah. So in the particular studies that were presented, we looked at mental health disability. So for example, we looked at pre-existing mental health conditions as a risk factor to development of, anxiety, depression, PTSD symptoms. But I agree with you, there are so many disabilities that we didn't really take into account to really assess their impact on people developing, psychological problems, which I think we should be taking into account in the future.
Yeah, absolutely agree. And what I would add is that sometimes the access to the information is difficult. Getting this type of information in the work that I presented, we're using health administrative data. It's not necessarily reported everywhere. Sometimes the better approach is to actually do the type of analysis that Sarah talked about, going into a more like individual level and tracking down their record. But I absolutely agree. The disability of information is absolutely important in those types of trying to better understand those heat-related health impacts.
Sarah, did you want to comment?
Well, I'll just comment that I agree with Eric in that individual level data is important. Defining disability is a bit challenging because there's lots of different components. And, when I'm talking about people with schizophrenia, I'm talking about people that have been identified based on their patterns of healthcare usage as someone who probably has schizophrenia. So it's an administrative diagnosis of schizophrenia compared with a clinical diagnosis. And we don't really have something like that for disability. We might be able to get at physical disabilities based on the prescription of certain devices or what have you, but there is no disability flag in the administrative data that we use. So we have to look to other sources to get that information.
Yeah, it seems like a room for opportunity to improve some of the things that we do. Certainly I think we talk about social isolation, that could also build into some of the heat effects of social isolation as well. Is there another question? Joy.
I was hoping if there's time for my questions. Thank you all for your presentations. I enjoyed them a lot. I have a question for Sarah, another question for Dr. Agyapong. So for Sarah, I appreciate in particular about how you highlighted the difference in indoor temperatures between those who have access to air conditioners versus those who don't. And I think like we see a lot about like air conditioners as a way to control the indoor thermal environment. But I was wondering, like from your experience in BC, like or in Canada in general, like do you see other factors related to the structure of a building that's relate to our like thermal environments that you think would be important to consider? Would you like to answer, or should I go right ahead to also asking the question for?
Let's let her answer that one first. Yeah.
Okay.
Yeah. Well, don't go anywhere. Yeah. Sarah?
Okay,
Yeah.
I'm answering. So in Canada, we design to retain heat. It's been a cold country. And that's kind of the primary concern when we're talking about indoor overheating in Canada is our buildings are designed to do that. So there's lots of opportunities to look at more passive ways to ensure that the indoor environment can stay cool. And my preferred method is some sort of combined approach between passive and mechanical cooling. But we have a long way to go to kind of get out of the mindset of keeping buildings warm in the winter, which we still need to do because it's still going to be cold in the winter, and allowing them to remain safe in the summer. So one of my favorite things that I think we need to look to is if you go to a hot city in Europe, you're going to see shutters or awnings over every single window. This is very easy to do, and keeping the sun off windows is going to keep the indoor environment 2 to 4 degrees cooler than it would be without those interventions. So I'm a huge fan of external shading of windows, which is a great place to start for existing building stock and new buildings.
Do you have another question, Joy?
Yes, I have another. So thank you, Sarah. My other question is for Dr. Agyapong. So it's actually a question I want to ask on behalf of my friend who works in tech, but she's also very interested like in improving people's mental health. And now we also understand like people's mental health in the context of climate change is also very important. I'm wondering, what would your suggestions for her be in terms of how she can think about how to engage in this kind of work about like being involved in like incorporating technology into improving people's health in the context of climate change?
Yeah, I think, if you look at the landscape of technology and mental health, for example, there are thousands of apps and online programs really to support people. Really, what's lacking is actually the evidence of effectiveness of these interventions. So, to get involved, my suggestion would be certainly to partner with academics who are doing clinical trials and really evaluating things in a scientific way. Because you can develop the application, but does it work? Does it really improve people? Are there any particular harms associated with the application that have been developed to help people? There are so many unknowns and so many questions that I think, so if you are in tech and you have the ability to be able to really develop, products to be useful, to partner with, kind of researchers to ensure that the products that are being developed are actually, validated, they are proven in randomized controlled trials, to be effective and safe, for deployment to support the population.
Thank you.
Thank you. I think we have maybe 1 or 2 more questions. Yeah.
I would like to give the opportunity of people on the Zoom, if they have questions first, before.
That's a great idea. Oh yeah, there are no questions in there? Okay, someone's moderating it. Okay. All right. Thank you, though.
Okay. Frédéric Fabry, Baylor School of Environment and Atmospheric Science. A question for Sarah and Eric. I was probably like most people here, surprised about the schizophrenia as being a strong factor. And you pointed to, Sarah, to some of the research about how they don't realize that they're being affected or they're being released. For example, when they stop exercising, their heart rate doesn't come back. So that's a key. Being able to rest in the cool is a key way to recover against heat stress. And that's what's being proposed, among other things, when we have these rooms, cool rooms, etc. So if people don't realize, both consciously and unconsciously, that the situation is getting better, that they need help, how do you help them?
Yeah, I talk about building a safety net around the folks in our communities who are the most susceptible, and really raising awareness that people with schizophrenia are at risk, because it does come as a surprise to most people when they think about who's at risk when it's hot outside. Well, they always hear people with heart disease, people with kidney disease, and it's never people with schizophrenia at the top of the list, although people with schizophrenia should be at the top of the list. So when I'm talking about this in groups, I'll often ask people to raise their hand if they know someone with schizophrenia, and most people are going to raise their hand. It's not a highly prevalent condition, but the point prevalence is somewhere between 1% and 3%. Most people know someone with schizophrenia. And if you tell them, hey, can you help check in on that person when it's extremely hot outside, we'll build the awareness and we'll build that safety net along with the other pieces that need to be done.
So that's where Text for Hope comes in, I suppose.
Yeah, exactly. And while Vincent was talking, I was thinking about that. Like, I'm sure there are some texting services that serve people with schizophrenia, or the care networks around people with schizophrenia. And what we do when it's smoky out is, like, Smart Mom is a text service for people who are pregnant, and we send a text message out to everybody who signed up to let them know that smoke can affect their pregnancy and the developing fetus, and to take some protective action. And something very similar could happen with extreme heat and people at high risk.
Okay. Two more questions. Yeah, go ahead.
Okay, very quick. Fiona Hanley, I'm a nurse associated with the ISON here. I'm also a part of a big network of nurses across Canada working on environmental and climate health. And I'm just thinking about some of the work that's being done. And, one of the things that health professionals do, and I could say particularly nurses, is translating science and bringing it into people's realities and their daily lives. And I wonder, with Sarah, for example, if you have done any work with BC nurses, for example, in bringing some of that work into the community of people who are working with schizophrenic people, for example, who are going into people's homes and communities and working with them directly. And I also think about that in terms of, what's happening in Montreal as well, too, and things like we're going to be having an election here, a municipal election, where some of the great things that we've been doing in the city for walkability, for cyclability, for accessibility for wheelchairs, for tree zones. I live in an area where they had most mortality in the heat dome of 2018, for example. Thinking about also how one translates that into also political policy as well too, municipal politics as well too. So.
Thank you. Maybe Sarah and then Eric.
Let Eric go first. I feel like I've talked
Take a break, Sarah.
Yeah. Thanks, Sarah. I think, Sarah, you've raised some good points. One thing I want to add, and I was thinking about that with the previous question, is the training of health professionals. It's so important, because one way of actually raising awareness is, what we're doing today, and making sure that policymakers, those urban planners and so on, are aware of those findings. But health professionals, those at the front line of treating those patients that are looking over those pregnant moms and those people who have chronic conditions, incorporating those environmental health issues into curriculum, it's so important. And I think that's one way, at least, to raise awareness.
That's a really good point, Eric. Sarah, did you want to add anything?
I guess I'll just say, I completely agree with Eric. At the same time, we're epidemiologists and we swim in our lane. So it really is mobilizing this evidence to the clinical partners who can work with it and do something with it. And we've been very engaged with the BC Schizophrenia Society on our results, and they've really taken them and run with them. And it is finding those pathways to the clinicians who can be effective that matters most.
Great. So the last question's from Zoom, and it's really about consensus on priorities. So do you guys have a sense of, when it comes to heat, what the best sort of policy interventions or policy directions we need to go in are? Is it sort of a combination of all the things you've been talking about, or is there one that sort of predominates your thinking about how to do this? Anyone? Sarah or Eric, I guess.
We need indoor thermal safety via whatever mechanisms we can achieve it.
Yeah, your point about people dying from indoor heat is a very, very good one. Absolutely. Eric?
Yeah, absolutely. And I think the work that is being done in the labs with your collaborator, Glenn Kenny at U Ottawa, it's some very interesting stuff, because absolutely we need some indoor thresholds. I think the one thing that I work on, and I think that seems to overlap several of our presentations today, it's really getting those projections and showing those burden on the healthcare systems, because money talks, and we know that politicians, those in decision-making positions, will want to see the numbers. And I think one way of doing so is by showing actually the benefits of intervening on some of the aspects that we showed today, in terms of how likely it can save us in the future, and looking not just short-term, but looking at long-term issues in terms of how it's going to cost the healthcare system and the society.
Excellent. Did you want to add anything, Dr. Agyapong?
Yeah, I think it's critically important that we, as we do the research, we come out with these findings to identify key advocates. It could be a politician, it could be an influencer, social media, it could be, service users, so that at least we can be able to take this to the top of the political agenda. It's not always that good things really are prioritized. So.
Excellent. So thank you so much, all the speakers, for coming and contributing your knowledge to us. We have a break now for 15 minutes, and thank you all for your attention. Thanks.
Thanks, everyone.